Hello, and welcome to Medical Radicast, your source for news and radical ideas about medicine and healthcare. To my more conservative listeners, some ideas will be radical because they diverge from mainstream medicine. To my more alternatively inclined listeners, some ideas will be radical because they merge with the mainstream. Either way, stay tuned, listen in, appreciate something known, and learn something new. I'm your host, Mitchell Cohn, Doctor of Osteopathic Medicine and Medical Radical. Here at Medical Radical, we seek to inform, entertain, and inspire you to take action to improve your life, your health, your community, the environment, the world we all share. Today's main topic: what I learned at a recent American Osteopathic Association Prolotherapy and Regenerative Medicine Conference, and why bucking the trend toward, quote, evidence-based medicine, unquote, may provide the only hope for real cures for health problems like chronic pain. But first, weird medical news. For this, I'll be joined by my wonderful wife and occasional podcast co-host, Elena Diamond. Hi, Elena.
Hi, Mitch.
Why don't you go ahead and start on the first story here?
Okay. This first story was from The Mirror in UK, and it's called Kiss of Death, Defiant Farmers Still Smooching Camels Despite Deadly Virus Warnings.
Did you say smooching?
I said smooching.
Smooching, okay.
The deadly MERS virus that are associated with camels and possibly bats.
And MERS stands for Middle East Respiratory Syndrome.
Found in lots of camels and maybe animal reservoir in Saudi Arabia. There's been 500 cases, with approximately 1/3 of those cases being fatal. Farmers, however, aren't listening to the authorities when they're telling them not to kiss their camels, and they're kissing them even more, and have gone on a rampage of snapping selfies, kissing their camels, and encouraging their camels to sneeze on them as well.
So farmers in Saudi Arabia who have almost nothing else all have cameras with which to snap selfies kissing camels.
Yes.
All right.
Yeah, this will probably be the plague that wipes us all out, and it's all because of camel farmers. Coming from tabloid might seem weird, but the research shows that in May of 2014, National Geographic backed up the claims that camels are the most likely hosts of the MERS coronavirus, and the farmers may be playing with viral fire.
Okay. All right, thank you. We're going to move on to the next bit of weird medical news, and it's titled Bullying and Health. Bad for victims, good for bullies? From Live Science at livescience.com. There was a study published in May of 2012 in the Proceedings of the National Academy of Sciences. The article states, and I'm quoting here, previous research has shown that childhood bullying victims may experience social and emotional problems as adults. No kidding, right?
Yeah.
However, bullied kids also tend to experience physical problems such as pain and report getting sick more often than kids who are not bullied. What did you say about the kids getting sick?
If they're studying children in school, if I was being bullied, I would stay home all the time because I'm sick.
Okay.
I'm sick. I don't want to go to school. I don't want to confront the people who are bullying me. If they're talking about later in life, obviously it's a residual effect of the bullying. It stays with you.
Right. And they did do this over a 20-year period, and it showed that the adults, these kids who had been bullied as children, as adults, showed higher levels of something called CRP, which is a measure of an inflammatory problem, and they had higher levels of this inflammation than the kids who had either been bullies or kids who had been both victims and bullies. So the kids who had been victims and bullies were somewhere in between. So health and bullying data from over 1,400 people collected over this more than 20 years showed this increased CRP. And my question is, what do we tell our kids now? Saying, don't bully. And yet they're finding bullying may actually help some of those kids.
Well, I'm going to have to go back and look at all my C-reactive protein, CRP, results and see where I landed. Because I was both bullied, but I also took care of the bullies who bullied me.
Okay.
So maybe this is Darwin's way of weeding out the weak, maybe?
Maybe. I don't think this is an endorsement of bullying. My question is, maybe if nobody does any bullying, then nobody may be at increased risk for inflammation.
That would be idyllic.
Yeah, it's just a thought. Okay, our next story, which isn't just weird, but I'm going to call it creepy medical news, comes from the Des Moines Register. And my worst fear is realized. Mosquitoes on the rise. I hate mosquitoes. Thank you. I hate mosquitoes. I'm allergic to mosquitoes, but they think I'm dessert. But even more weirdly, this was reported on by a Dr. Yogesh Shah, who's an associate dean for global health at my Osteopathic Medical School alma mater, the Des Moines University College of Osteopathic Medicine. Quote, of all humans who have died in our history, 50% have been because of malaria, unquote, he said. Malaria infects about 200 million people a year and causes 600,000 deaths, mostly in Africa and mostly in children. And he goes on to say that every increase in temperature by 1 degree, I think he means 1 degree Celsius, can increase the mosquito population by, quote, almost 8 to 10-fold, unquote.
Wow.
Yeah, that sends shivers up my spine. The number of malaria cases in the United States is small but growing, with a 50% increase between 2008 and 2011. Other mosquito-borne diseases likely to get me, because they do think I'm dessert, are a dengue fever. Oh, I can't even pronounce this one. Try that.
Chikungunya.
Thank you. And West Nile virus, which we all know is present in the U.S.
Yeah, that's a biting article there.
Thank you.
The next story is also from the Mirror. Great news if you're short, fat, bald, and smelly.
Oh, I've got that covered.
No, well, not all of them.
Okay, I'm not smelly.
Some of the benefits going to gray, bald, fat, or even smelly. Short men are likely to live longer due to an expression of a protecting gene called FOXC03.
Oh, does that mean I'm foxy?
Well, this surprised me because I always heard that tall men made more money. So apparently tall men make money and then die really
so
quick.
You still should have married a tall man.
Well, I guess it has its advantages. It depends on how you look at it. Short women, I think, honestly, short women, less likely to get cancer, so that's good. I have that on my side. According to the Oxford University study published in the Lancet Medical Journal, I think this story's leading toward the fact that hobbits live longer. Unpopular people, well, this was kind of, I don't know, I kind of looked at this and went, duh. But unpopular people are less likely to be infected with bugs because they don't come in contact with people.
Well, that explains why I'm fairly healthy.
Baldness. In men, high testosterone levels are thought to be linked to male pattern baldness. And a study in the University of Washington also found that men who develop bald spots and receding hairlines have a 29 to 45 reduction in the risk of developing prostate cancer. So that's a plus.
Okay.
Captain Picard has no worries down there. Big noses.
I do have that covered.
Big noses. Surprisingly, having a big nose means you're less likely to become ill as a result of breathing in germs. I would think you breathe in more germs, but
that's what they thought in the article.
But the University of Iowa research showed bigger noses may serve as a barrier to germs.
And I'll bet it's the greater number of nose hairs, because I know I have a lot more of those, in a longer nasal passage. So don't cut them or pick them anymore.
So you've got a longer filtering system.
Exactly.
You can find more info on all the things we've been sad about having, which now may turn out to be a good thing. Going to www.mirror.co.uk/news/weird-news.
All right. And our last weird medical news story, actually, this has been in the news, believe it or not, for, well, from when my research shows it goes back at least 2 years. Fecal transplants. Yes, folks. Fecal, as in poop, transplants.
That's deep.
Reported in numerous reputable medical and layperson journals, including Scientific American, Discover Magazine, Huffington Post, and many more, and even the National Institutes of Health, and endorsed by the Mayo Clinic. Transplanting healthy, helpful bacteria from healthy individuals to unhealthy people may help or cure a number of problems, including ulcerative colitis, Clostridium difficile, which is a very difficult to treat diarrhea, which often results from antibiotic treatment, chronic constipation, irritable bowel syndrome. This one I thought was very interesting, Parkinson's disease. It's not exactly in the bowel. Various autoimmune conditions such as multiple sclerosis, rheumatoid arthritis, even type 1 diabetes, and possibly chronic fatigue. And there were actually a number of other things listed in the articles which I reviewed. An NPR report from September 5th of 2013 quotes biologist Jeffrey Gordon of the Washington University School of Medicine in St. Louis and his colleagues when they removed bacteria from the guts of 4 pairs of human twins, in which one of the twins was obese and the other was lean. The researchers then transplanted those microbes into the guts of lab mice, not into the other twin, into lab mice who didn't have any of their own gut microbes. The mice that got microbes from the fatter twins gained more weight and fat even when all the mice ate identical diets. That's pretty interesting. Then the scientists let the animals live together, and I'm quoting here, and since eating each other's feces is a common habit among mice, they were soon exposed to each other's gut microbes, unquote. Lo and behold, the fat mice picked up the lean microbes and they lost weight. And finally, the researchers showed that the animals were unable to be colonized by the lean microbes when they were fed diets aimed at simulating a typical unhealthful Western diet high in saturated fats and low in fiber, which means these animals, even though they were given the microbes from the lean twins, still got fat eating the diets that you and I eat. Although we're trying to be better than average, it explains where I am. But anyway.
So this pretty much says that big girls should follow Paris Hilton around and into the bathrooms.
That is a disgusting thought.
It makes sense in my head a little bit, but the thought of getting a fecal transplant is a little off-putting.
Well, I understand that, but you know what? Believe it or not, they're now working on fecal pills that you can take. I hope they're capsules.
Yeah, me too. Yeah.
All right, in any case, don't try this at home. I don't think having your spouse's lean microbes is going to make you any skinnier.
I'm sure there'd have to be some processing put in place to
I
make this work the right way.
All right, we're going to take a short break and we'll be right back. We are back. I appreciate your help, Lena. Thanks. She will be back later on in the podcast. For right now, I'd like to talk about the American Osteopathic Association Prolotherapy and Regenerative Medicine Conference that I went to last week. It's going to be a little more rambling, but there's some really interesting points that I want to cover. The first is, it was really amazing to me to be in a group with such like-minded people. Many of them were MDs, not DOs, and people came from all over the world. We had people there from the Philippines and Thailand, Canada, Mexico, Hong Kong, Italy, and I don't know where else. And there were only about 50 of us. But the things that I wanted to say are, first of all, I admire all the MDs who were there. They were thinking way outside the box. But there was a noticeable difference. Okay, well, there was this one guy. His name was Dr. Stan Lam, a tremendous lecturer who's an MD, and he lived in Hong Kong. I don't know if he was trained in Hong Kong originally. He also lives in the U.S. at least half-time and practices in both places. But he's also trained in osteopathic manipulative medicine, I understand, through Michigan State University's College of Osteopathic Medicine. He also does prolotherapy and PRP, which are some things that we have discussed and will discuss in the future in more detail. He does something called hydrodissection, which is really cool. We saw ultrasounds that showed how you could stick a needle in next to a nerve and just essentially squirt kind of a sugar water in there, and it would separate the nerve from the tissues and break up scars, and you could instantly get rid of pain. It was a beautiful thing to see. He does use the occasional dry needling, which is just what you do like in acupuncture, But he avoided talking too much about that because he didn't want to talk about chi, which I found interesting. He explained chi, which a lot of people know as related to energy or health or vitality. He explained it more as an electrochemical process or even allowing or releasing gas into the area. Anyway, very interesting stuff, but he was not a Chinese medicine practitioner. He is an MD, but he incorporated all of these things, including osteopathic treatments. Still, there was a noticeable difference between those who were MDs, who were not used to using their hands for palpation to diagnose. It's a nice fancy medical word which means using your fingers to touch, to feel things to diagnose. But there's a difference between the MDs who were not used to doing that and the DOs who have done so on a regular basis. You could tell who were the practiced palpators and interventionalists. But what was really important was a couple of things. Some important takeaway points from this conference. I was taught in residency that once the body has developed chronic pain, that it makes changes in the brain, and those changes are things you can see on what's called a functional MRI of the brain. And even if you fixed the cause of the pain or got rid of the limb that was injured, those pain sensations would always be present because the brain had been changed to register pain and would always register pain no matter what you did for that person. But in my 27 years of being a doctor, I never found that to be true. If I found someone, even if they'd had pain for 40 years or more, if I could find a cause for their pain, a vertebra that was flexed or that was held in place by a scar, a muscle that was contractured, which means contracted, like spasmed for a very long time, in some cases for 30 or 40 years, or a damaged ligament, if I repaired it or set it right, their pain went away. And so I couldn't adhere to this, quote, common wisdom, unquote, that's still spouted almost everywhere, at every pain clinic, at every spine and pain institute. They say, well, we can't get rid of the pain, we can cover the pain, but it's in your brain. And there was actually a Discover article about this recently, believe it or not. And not only did this group at the AOA PRM meeting not believe it, and honestly, I'd always thought I was alone in my experience, but apparently some of them found that there is we'll call it a new train of thought going through pain circles, where now at least a few researchers believe that pain is never really what they call centralized, meaning it's never really in the brain. Yeah, you can see it on the functional MRI, but it's just showing that you register pain. But that does not mean the pain has undergone a permanent change that will make you register pain all the time. They believe that there is always a peripheral cause for the pain, meaning somewhere outside the brain, and what we need to do is find it and fix it. I felt so vindicated. It was amazing. Now there's another problem, what I call the pebble in the shoe. And I'll tell this story very quickly. I tell it to a lot of my patients. A man is walking along, and he's just fine. Suddenly he gets a little pebble in the shoe, so he leans away from that foot. But he keeps walking. After a little while, he gets a pain in one side because of walking a little funny, so he twists a little bit, and he keeps walking. Now that he's twisted, he's starting to get pain in the neck because he's all twisted up. So he twists a little more, gets his head a little resettled, and he's doing okay, and he keeps walking. And this goes on, and 3 years later, he's got the worst headache of his life, and nobody can figure out what the problem is, because everybody's looking at his head to find the cause of the pain. But the cause of the pain comes from that pebble in the shoe. But you layer compensations. He compensated for the pebble in the shoe, then he compensated for the new pain in the side, then the new pain in the neck, and so on. So you need to peel those layers off. So in other words, one injury, no matter how small it is, can set you up for future injuries if that initial problem isn't taken care of. If you don't take the pebble out of the shoe, you will probably have problems down the road. So, if, despite having no specific treatment to correct a problem, a person with pain adapts and becomes pain-free, at least for a time, though the problem hasn't been corrected, it can set them up for future injury and pain, which may even seem unrelated down the road. Like I was saying, headache from a problem with the foot. Now, another thing was there was a gentleman who, like me, does nothing but hands-on medicine, treating chronic pain, acute pain, etc., with manipulation and with prolotherapy and such. And I've always felt, well, I couldn't put it into words well. I couldn't get it out. But I felt that I never liked this idea of what they call evidence-based medicine. Now, evidence-based medicine sounds like it makes sense. Everybody touts this evidence-based medicine as the only way medicine is kept scientific, as the only way you should ever be convinced to change your medical practices. You've got to have the studies. You've got to have the numbers. Now, there are severe problems with this, and I just couldn't figure out how to express them, to define the problems. For instance, for going on 30 years, I have seen miraculous recoveries from chronic pain. Just go to my website, www.mitchellcohn.com. It's MITCHELLCOHN, all one word, .com, and look at some of the video testimonials to get a small idea of what I've seen. According to this doctrine of evidence-based medicine, though, I should ignore what I've seen and experienced. I haven't done rigorous scientific studies. I've just treated people and made them more functional and pain-free. According to the doctrine of practicing only evidence-based medicine, I shouldn't have been helping these people with my hands or my needles. I should have been sending them for tests and more tests, which would show nothing was wrong, and for surgeries that wouldn't work, and for medications that would simultaneously fail to actually make them better, but would addict them nonetheless. I'm sure this would have made the pharmaceutical companies and the spine and pain clinics, the surgeons and the hospitals quite happy. Even for the few studies that were done on osteopathic manipulation in a fashion that was acceptable to the medical establishment, there were terrible flaws and the conclusions were awful. But those flaws allowed the medical establishment to feel very good about itself and the useless treatments that they were perpetrating upon the public. Now, let me give you an example. There have been, I believe, 2 studies that got published in JAMA, the Journal of the American Medical Association, which, as you know, has nothing to do with osteopathic medicine. It's all MD, or what we call allopathic medicine. And those studies showed that osteopathic manipulative medicine, or OMM, was, quote, as good as, unquote, MD medicine for low back pain, but only as good as. God, that bothered me. I always found so many flaws with that logic. The first was the studies always talked about how the patients were 6 months or more out from the original injury. The truth is, most people, regardless of the injury, will generally heal or adapt, as I talked about in the pebble and the shoe story, to the injury without going into a chronic pain state. Most will heal or adapt without pain between 3 and 6 months out, even if you do nothing for them. But good osteopathic treatment early on means these people don't have to suffer or wait for 3 to 6 months before their pain is gone. We might be able to remove the pain in 5 minutes, or put back what's wrong, or get them pain-free and fully functional within 2 weeks, but not necessarily 6 months. Now, here's a good place for me to insert the featurette, Osteopathic Moment, and then we'll continue with the story, but I think this is important here. I had a gentleman come into my office, a big man. He had injured his back 11 years before he came to see me. He couldn't lie down in a bed. He couldn't lie down on a floor. He had to sleep sitting up in a chair for 11 years. No MDs could help him. And as soon as he presented to me and I did my examination, I knew what was wrong with him. And honest to God, it took me 2 seconds to fix him. And he was amazed. Now, a few months later, he got a completely different back injury. He had a muscle spasm, which had absolutely nothing to do with his original injury. Wow, that took me, I think, 15 minutes of work. But you got to remember, this is a big man, so it was a lot of work. 15 minutes. And then he was done. And a few months later, he came back with back pain. And guess what? This was unrelated. It wasn't even in the same region of the back that he had before. And I literally had it fixed in 2 minutes. So the point is, there was never a good comparison of short-term versus long-term outcome in these studies. And I've always had problems with other things, like patient selection. The doctors participating in the study would take and randomly assign patients with any undefined low back pain, and they would put them in treatment groups or non-treatment groups. But that's not the way you should do it. You have to pick patients that are appropriate for treatment with osteopathic manipulation. Not everybody is appropriate. If a person has a torn ligament, osteopathic manipulation is not by itself the proper treatment. But that's what they were doing. They were throwing people into these different groups. To do it properly, the patients first need to be examined, and it needs to be determined what type of injury they do have, whether it's a ligament that maybe needs prolotherapy, or a vertebral dysfunction, as we call it, meaning they got a flexed vertebra that's stuck, or as chiropractors call it, subluxed, which is really a misnomer, but we won't go into that. Or whether they have a muscle spasm that can be easily fixed by appropriate stretching. And then you put them into these groups and say, those that have lesions that are considered treatable by OMM, in other words, good patient selection based upon diagnostic criteria. And then ask the question, are they better off if they are treated with OMM or left to recuperate with various other therapies such as physical therapy, which is essentially random, injections, medications, a watch and wait type of treatment, etc., which are the most frequently utilized therapies by MDs, I should add. The watch and wait, the physical therapy, medications, injections. Not only that, but what about the expertise of the operator, meaning the physician? When I was fresh out of school, and even when I was fresh out of my postgraduate training, I had nowhere near the expertise that I have now. I can diagnose and treat things with my hands now that I could never do before. I can recognize things now that I never could before. So operator experience is just as important as, say, operator experience in doing gastric bypass surgery. Surgeons with relatively little experience have far more problems with diagnosis and treatment and far more complications than people who perform the same procedures but have far more experience. There was a surgeon, when I was in my internship, I observed this guy who was new to laparoscopic gallbladder removal, and he was terrible. He constantly nicked the gallbladder and leaked potentially infected bile into the abdominal cavity with a potential for causing deadly peritonitis. In the 3 surgeries I observed this guy do, he damaged the gallbladder and leaked bile every single time. Now, 5 years later, I'm sure he had done hundreds of these, and I doubt he was still having the same problems. The point is that operator experience has a lot to do with whether or not OMM is successful, just like whether or not surgery is successful. These kinds of things were never, in my opinion, taken into account. These confounding factors were never addressed. So the thing that the doctor I was speaking to at the AOA conference expressed so beautifully was this. He said he hates and does not agree with or believe in this idea of evidence-based medicine, which is touted so loudly and used to make hospital guidelines and practice guidelines and determine whether insurance will pay for particular treatments, because in order to be considered, quote, evidence-based medicine, unquote, a study, or more likely many studies, about the subject or procedure have to have been published in peer-reviewed journals, and usually multiple peer-reviewed journals, and they have to have multiple studies, and things like osteopathic manipulation are never going to have that. Very few studies will ever be done that will meet criteria for publication in prestigious medical journals, and even when they are done, we end up with garbage like those 2 JAMA reports, which say OMM is as good as standard medical garbage treatment because the studies were not really properly done. This doctor said that the studies that do make it into these journals are included only if they meet the criteria, and get this, and the agenda of the editors. And these editors are, first, generally MDs. They are generally anti-CAM, and CAM stands for complementary and alternative medicine, and they must consider their journals' backers and advertisers, who are primarily pharmaceutical companies, medical device companies, and corporate medicine companies who do not wish studies that do not enhance their profits to be published. Now, unfortunately, there's literally no profit for such companies in promoting OMM, prolotherapy, neuroprolotherapy, etc. as medicine and medical devices are not generally used or promoted for these treatments, physical therapy and hospital visits and stays are reduced or eliminated, and recurrent fees for spinal and chronic pain centers would actually be reduced. This provides a marked disincentive to publish positive CAM or OMM or prolotherapy articles or such. There is really only a single osteopathic journal in the entire United States which publishes osteopathic-related research. So 99+% of peer-reviewed journals almost exclusively publish articles which further the agendas of corporate and pharmaceutical companies. The things doctors like me do, however, make people better and less dependent upon chronic treatment and therefore do not advance those groups' agendas. So I know I can cure somebody that someone else might not be able to cure using standard treatments based on, quote, evidence-based medicine, unquote. But what I do is never, well, at least not in my lifetime, going to be considered mainstream medicine or part of evidence-based medicine, even though we have multiple studies. They're never going to be accepted for publication or published widely enough to impact how medicine is practiced. Also, going back to the MDs that I do admire, like the ones at the conference, and really, it's a wonderment to me that these people are willing to go out on a limb and do these things and work with their hands and try a whole new way of practicing. Some of them may have been in practice for 10, 20, 30 years, and the problem is this. They're trying to think holistically. They're trying to think neuromusculoskeletally like DOs are supposed to think. And I'm very proud of them for that. But they've got a late start. Some of them, if they start young enough, may get to be very good. But for the most part, they will have lost 20 or 30 years of training compared to a DO who is essentially given this training as a gift, as part of our education from day one in medical school. And these MDs think and try to act more osteopathically, holistically, and sensibly than most of the members of my own osteopathic profession. If we could just get osteopaths to think about manipulative medicine, about neurological musculoskeletal concomitants associated with organ problems, if we could just get osteopaths to think about osteopathic manipulative medicine or approaching a problem holistically and get that to the forefronts of their minds instead of either a last thought or no thought, we would still be way ahead of even these MDs who are trying to catch up. But what's odd is that these MDs, these late bloomers, are going to be ahead of many DOs, the majority of DOs in fact, because DOs no longer think as a group as osteopathic physicians have been taught to think. I think that's a very sad thing for our profession because we have so much to offer, but we are now having to train people outside of our profession. Not that I'm against sharing this information, but we have to. We are forced to train people from outside our osteopathic profession if we are going to keep osteopathic style manipulation and osteopathic thought alive. And that is sad, and it shouldn't be that way. Let's take a short break. We're back. For the last part of today's show, we would like to do a public service announcement. At least we think it's a public service announcement. It's about medical marijuana. Cannabis can be really helpful. Now, I did medical marijuana evaluations, physical examinations, and certifications for years, ever since it became legal in my state. I had to fight the bad guys in the government who didn't want this to go on. I had to fight the bad guys in the medical marijuana business. There were some people out there who were simply weed peddlers, and they really didn't care about the medical side of it. And I had to fight doctors who, I am sad to say, were simply out to make a buck and really didn't have any medical ethics. But I went and I studied medical marijuana. I went to conferences. I learned some amazing things. I even wrote a brief book on this. turns out that the cannabinoids, they're just one class of chemicals, can be used to cure skin cancer. And the cannabinoids, this is not the THC, which makes everybody high. The cannabinoids are a different part of the marijuana chemicals. They work amazingly well for things like seizures, which we'll talk about in a second. And I learned that people who have chronic pain don't have to get high. They don't even have to get a buzz to get pain relief, and so much more. Now, ever since this started back in, I think it passed in 2008, my state's been trying to make it harder and harder to get and to stamp out medical marijuana. They finally seem to have come to some kind of agreement. There's a middle ground, but I certainly don't see it becoming a widely legal substance here. But there's some rather interesting news, and I think I'll let Elena take it from here.
I recently heard on a TED Talk a group of brothers, they were biochemists, and they had bred medical marijuana with no THC. So it had all the, you go ahead and say that word. Cannabinoids, and other chemical constituents, but not the THC.
THC?
Yeah, no high.
We can't get high.
Right. But virtually in all the cases and for all the causes, that it's needed for. So the Weedmeisters, they lose out in this. However, the TED Talk detailing what they'd accomplished showed how this non-high cannabis is so effective at helping people. It had example of children with seizures that had seizures every few minutes.
I have to say, this was amazing.
It was.
On the TED Talk. You've got to see this. They showed kids who lived in a perpetual fetal position because they couldn't move. They were having
their whole life. Every 15 minutes they were in a seizure.
Or less.
They couldn't learn. They couldn't exist other than in a seizure state.
Right. They didn't know if they had personalities because they never came out of the seizures.
But on first treatment, the seizures stopped.
Very first treatment.
Wow. And stopped, and with subsequent treatments, virtually cured. Mm-hmm. In some cases, with no more seizures.
No more seizures, and no more of the other medications they'd been on?
Right. They were on bottles and bottles of pills. Lord knows what the side effects were of
that
those.
Never worked.
That didn't work anyway. They never stopped the seizures from happening in these poor kids.
So it's an amazing, amazing treatment for, we're talking small children. Now, these kids are not getting high.
Nope, not at all.
They are only getting the medicinal benefits.
This is actually a miracle drug.
I agree.
And we should be shouting it from the mountaintops, but it's still illegal to ship. They're still treating it as a drug, even though the high is taken out of it. So there are kids contacting this group of brothers, and we don't have their name here, but we've got the link to that will be in the notes of the talk. But these group of brothers are being contacted, hounded by parents across
from all over the
world, saying, please help my children here, please send me the drug, I'll pay you. And they can't. They'll end up in jail because it's illegal to ship across state lines. So the only thing that can happen is all those people have to find a way to get to them. And in one of the cases, one of the families, they had no money to get their child there, and their child died.
That is very sad. So they either have to be wealthy enough and or mobile enough to move to, is it Colorado they're in?
It's in Colorado.
You have to either be able to get there, or your child will suffer for the rest of their lives. It's a very sad story, but it is amazing to see what these young men have done.
Well, you've never seen a pharmaceutical pill work like that. Right. In one dose, you're better.
Right. So there will be a link on my website, mitchellcohn.com/blog. We'll have a link to the TED Talk. I strongly, strongly recommend you watch it. It is both sad and uplifting at the same time, and it gives me a great deal of hope for many people, kids especially in this case, who suffer terribly, and a little medical marijuana can go a long way. And
when you watch the TED Talk, I think there's a link to these biochemist brothers, their site, and they are taking donations. It's a very worthy cause. I help them figure out how they can get this to more people, how they can change the laws, or help bring other people to them who can't afford to get to them.
All right. Elena, thank you very much.
Thank you, Mitch.
I want you to know your feedback, comments, concerns, even personal stories are welcome. You can either write to me, Dr. Mitchell Cohn, at Medical Radicast at medicalradical.com, or you can call and leave your feedback, comment, or story as a voice message on our Skype line at 734-931-MRAD. That's 734-931-6723. Your voice may even make it onto a future podcast. Thanks for listening to Medical Radicast. I hope you've learned something you didn't know before, been entertained along the way, and will now maybe even take action to improve your health or healthcare, whether doing a little research, looking for a new doctor, or even just being willing to ask more questions to the people you've trusted with your healthcare for so long. Your health is in your hands, and that, my friends, is a radical idea. It's been my pleasure to be your host on the Medical Radicast. I look forward to speaking with you next time. This is Mitchell Cohn, D.O., the Medical Radical.
I got out my bed early this morning. Down the road I go. You know I love you, baby. That is you. You know I love you, darling. I give you everything you need. Well, my baby, she used to lay. Now you did take it easy, baby.
Hello, and welcome to Medical Radicast, your source for news and radical ideas about medicine and healthcare. To my more conservative listeners, some ideas will be radical because they diverge from mainstream medicine. To my more alternatively inclined listeners, some ideas will be radical because they merge with the mainstream. Either way, stay tuned, listen in, appreciate something known, and learn something new. I'm your host, Mitchell Cohn, Doctor of Osteopathic Medicine and Medical Radical. Here at Medical Radical, we seek to inform, entertain, and inspire you to take action to improve your life, your health, your community, the environment, the world we all share. Today's main topic, beware hospital care. But first, in the news. From the April 22nd, 2014, The Atlantic, there was an interesting article on prescribing mushrooms for anxiety. The Monthly has a remarkable article about a New York University research team researching the anti-anxiety effects of psilocybin, a so-called psychedelic drug derived from mushrooms. It's used to get rid of, not reduce, but actually get rid of anxiety in cancer patients. It turns out that in the study, 3/4 of the patients had positive effects. I'm not sure what that means for the other 1/4, but it's very interesting to note that there are a number of steps that were taken to try to provide everyone with a more positive trip, so to speak. They used very careful preparation. They made a room for the patients that was blue and had clouds. They encouraged the patients to bring personal objects with them for comfort. There were 2 psychologists in attendance for the entire 8-hour experience. And in an interesting nod to shamanic traditions, shamans all around the world have used psychedelic preparations for, well, maybe 9,000-10,000 years. In a nod to those folks, they actually have stone mushrooms, tribal artifacts, and fresh flowers in the rooms. Now, as I said, not all experiences were positive, but most of them were. What was interesting was that they had Valium to give the people if the anxiety worsened, and there's an actual antidote that has and I'm quoting this, almost instantaneous antidote to the psychedelic called Zyprexa, which is a prescription medication. The important takeaways and conclusions from this were that the experience is unique for every patient. And contrary to the government credo that psychedelics are addictive and are horrible medications, there actually were found to be no addictive properties, and the medication was found to be very safe. The positive effect is so real and so positive, in fact, that it had an enduring effect and major effect on things such as post-traumatic stress disorder. It didn't cover up the patient's anxiety. It actually got rid of their anxiety episodes. The article quoted one patient, which they dubbed OM, quote, "At the hospital, they gave me Xanax for anxiety," he said. "Xanax doesn't get rid of your anxiety. Xanax tells you not to feel it for a while until it stops working and you take the next pill. The beauty of psilocybin is it's not medication. You're not taking it and it solves your problem. You take it and you solve your problem yourself." Unquote. Now, I should point out that this is a very small study. There are only 32 people involved, and more extensive research needs to be done. But it's still an extremely interesting finding, and hopefully they will continue to do further, more extensive studies into the medicinal effects, positive effects of psychedelic medications. Now, on to today's main topic. Beware hospital care. I've been a doctor for more than 25 years. About a year and a half ago, however, I saw medicine practiced from the other side as a patient. Over a 4-week period, I was in and out of the emergency room 4 times, once each week. I was hospitalized as an inpatient twice during that period, one time for 2 days and the second time for 6 days. It was actually a very enlightening and extremely disturbing experience. The picture isn't pretty. In fact, the reason I was in for 6 days instead of just 2 days, the second time, is in itself an interesting story which we'll go into. Now, back in the old days, that would be 10 or 15 years ago, most doctors who were in practice had hospital privileges. In other words, they had the right to admit and take care of patients in the hospital. So when you were, for whatever reason, admitted to the hospital, your own doctor or one of his or her partners would care for you during your stay. Over the last 15 years or so, though, a new medical specialty has developed. It's called the hospitalist. A hospitalist is someone who does not see patients outside the hospital. They don't have a family practice. They don't have a practice in some specialty. Their specialty is hospitalization. The hospitalist works 8 to 12 hours per day doing nothing but taking care of hospitalized patients. As a result, any doctor can send a patient to the hospital, never have to come in and see their patient, and the patient will be tended to and well taken care of by someone who specializes in caring for inpatients. Now, I admit, when I first learned of this arrangement, I definitely approved. Doctors didn't have to start their days by doing hospital rounds at 6:30 or 7 a.m. before they could go see patients in their office at 9, and they could go back to see their hospital patients after office hours were over and work until 7, 8, 9 p.m. at night. And as a doctor, I felt this made great sense. Physicians wouldn't be tired and cranky and prone to errors all the time. Unfortunately, my experiences have shown me there are some major failings of this new system. When your own doctor or someone intimately tied to your doctor, people who had a vested interest, and I say had because when you're put in the hospital now, your doctor doesn't exactly have a vested interest in the care you receive in the hospital. In fact, as I learned, no one really has a vested experience in your health care while you're in the hospital except for you. When you're in the hospital, and your own doctor would be the one who would care for you, there is a personal connection with that doctor. And I found that hospitalists lack that personal connection. To them, you're just the patient in room 371, and that's being generous. To some, you are just the object or the infection or the heart attack in room 371. Now, don't get me wrong, the hospitalists that I saw were all very courteous, kind, and well-groomed. Not like the harried, disheveled doctors of my youth who flew into the room, sat with you, and discussed what was going on. No, these polite doctors never sat down, never developed anything even approximating a personal connection, and though they ambled easily into the room, as soon as I started asking questions, they seemed disturbed and flew out of the room. I should say that I was really quite seriously ill. I normally have slightly high blood pressure, among my other ailments, but since developing a rather serious, potentially life-threatening throat infection, I suddenly developed hypotension. That means the inability to keep my blood pressure up in the normal range. Now, normal pressures would average around 120/70. The lowest acceptable pressure is about 90/60. My pressures normally ran close to 140 over maybe 86. My pressure while I was ill was at one point 79/45, and somehow I was still conscious. All anyone seemed interested in doing was taking my blood for bacterial cultures, giving me random antibiotics to see if they could get rid of it, fill me up with fluids intravenously, and send me home. After the fourth emergency room adventure and first 2-day stay in the hospital, I got the impression that nobody actually wanted to find out what was wrong with me. I have to admit, I was shocked. My conclusion was that A, there was no personal connection with any emergency room doctor or hospitalist, so frankly, they didn't give a damn. And B, I got the bad feeling that I was being rushed out of the hospital as soon as possible. Now, pushing someone out of the hospital makes sense if you understand how managed care works. A hospital is paid by the disease you have, not by the amount of care or kind of care you receive. For example, if a woman delivers a baby, the normal stay allotted by a managed care company may be 72 hours. The hospital will receive payments to cover that amount of care, whether the patient stays 72 hours or not. If the patient stays an extra day, the hospital loses money. But if the patient leaves the hospital in 48 hours, the hospital receives pay for an extra day, which is pure profit. So what's the logical conclusion? Get rid of the patient as soon as humanly and safely possible. Most women are shoved out of the hospital within 48 hours of delivery. I began to think that the hospitalists, who are, of course, employed by the hospital, had a mandate to get people out of the hospital as soon as possible in order to maximize profits. That changes the paradigm of hospital care completely, doesn't it? We used to go into the hospital if we couldn't find out what was wrong in order to maximize the possibility of finding out what was wrong and fixing it. The new paradigm says we go into the hospital merely to stabilize the patient so they can be sent home, and most of the testing, as long as we can keep the patient stable at home, should be done outpatient because it's cheaper that way. Well, silly me, I'm just a patient and an old-fashioned doctor who didn't realize I was about to violate the new paradigm. I told the fourth emergency room doctor I refused to go inpatient a second time unless I was certain someone was going to make a real effort to find out why I was ill, what the infectious agent was, and why I keeled over every time I stood up. In other words, why my blood pressure was in the toilet. I demanded a consultation by an infectious diseases specialist. The emergency room doctor assured me I would absolutely get that consult. So, okay, I let them put me back in the hospital. What happened next is what confirmed my suspicions that the hospitalists were not on my side, but were on the side of the hospital's chief financial officer. After doing exactly the same things for 2 days that were done during my first hospitalization, and that is random antibiotics and blood cultures which showed no bacterial growth. I mean, why would they show any bacterial growth? I'd been on 6 different antibiotics over the prior couple of weeks. So what was going to grow? And of course, they hydrated me via IV fluids, which artificially raised my blood pressure. As long as you keep fluids dripping in, your blood pressure will stay up. The hospitalist came in all grins and wanted to send me home after the second day. And I said, what about the infectious diseases consult I was supposed to have? The hospitalist smiled broadly and said, "Oh no, I don't think we need to do that." I was not smiling. "Yes, you do," was all I said. She unhappily relented, and I have to admit, she backed out of the room. She didn't even turn around to walk out. She was afraid of me. But I got my consult. The hospital was forced to keep me for 6 days since random checks showed that if they stopped the fluids, my blood pressure would plummet And the infectious diseases doctor decided to not only run all kinds of infectious diseases tests, but he said, I think we should run another test to see if there's another reason you can't maintain your blood pressure. Now, no hospitalist thought to run that last test, or any other test for that matter. Only the private doctor that I brought in thought to do it. Now, I won't bother you with further details, but it is sufficient to say that this private doctor found the cause of my infection, but also found I had an underlying problem with my adrenal glands, which had been exposed by the infection. That's why I couldn't maintain my blood pressure. Now, a week later, talking with my own doctor, who is an internist, in his office, after he'd studied all my test results for half an hour, he gave serious thought to all the implications and decided what else needed to be done to make sure I would get healthy and stay that way. I mentioned my observation to him about hospitalists that I believed their only real function is to get patients out of the hospital as quickly as possible to maximize hospital profits. He smirked, but sadly, I thought, and he confirmed and said, and I'm quoting, "That is the unwritten rule of the hospitalists," unquote. Is this how we want our healthcare to be? Let's take a short break. Before we get back to our main topic, beware hospital care, there's something I want to say that's really been bugging me. I went to a theater, and I've seen this a couple of times. I've been in the theater over the last couple of months to see movies, and I believe there's a little bit of government overreach. There's actually an advertisement in the theater which shows people watching other people and tells us to be on the lookout for anything suspicious. If someone leaves a briefcase or a backpack, they put it in a context like we're doing our neighbors a favor. They made it look good. But if you dig up any old Nazi propaganda, that's exactly what the Nazis did. They had people spying on their neighbors. They encouraged children, 6 and 7 years old, to spy on their parents. That's not a service. If anyone has ever recalled seeing the old version, not the new version of the television series, but the old version, they made scientists the new Jews. Everyone was to watch the scientists. They were to tell if anyone was doing anything suspicious. I cannot believe that in this day and age, in the theater that I went and paid $7.50, $8 to go see a movie, I just got preached to by the government to spy on the people who are sitting next to me or across from me in a restaurant. Enough for my radical rant. Let's get back to our main topic. Beware hospital care. Now, since my own hospital stay, I've been hearing numerous other horror stories. Let me tell you a little story about my sister-in-law's stay in the hospital. This was really interesting. She has a history of heart problems, and she'd been in and out of the hospital a number of times recently for heart problems. She was describing some chest pain, and she called her doctor, and he wouldn't even listen to her. He said, "Go to the hospital now." And she did. Now, by the time I got to the hospital to see her and visit, she'd been there for a day and a half. Now, I am, as I said, kind of an old-fashioned doctor. I believe that you get 85% of all your diagnoses by listening to your patients. If you talk with them long enough, they will probably tell you what's wrong with them. You get the rest by doing a physical examination, and if you have to, you do some tests, maybe an X-ray or an MRI if you need to. But those are not your first resorts, those are your last resorts. So here I am sitting in the hospital with my poor sister-in-law who's just dying of pain. And I talked with her. I said, "What does it feel like?" She said, "It's burning horribly." Okay, in my mind, I understand that some heart disease, especially in women, manifests a bit differently, and they have some burning, but there can be a lot of other reasons for burning. And her chest, I went and checked her rib cage. It was just hard as a rock. So I'm sitting there in the hospital bed, with my brother-in-law watching, working on her, trying to make her feel better. And as I did my hands-on manipulation, she lay back in the bed. She said, "Oh my God, that is the first time I can lay back comfortably in 2 days." And the nurse came in and saw me working on my sister-in-law doing osteopathic manipulation. And as explanation, my sister-in-law simply said, "It's okay, he's my brother-in-law." In any event, I talked further with my sister-in-law. She was laying there a little more comfortably. And she said, "It just kills me to even swallow water." And boom, there was the answer. I said, "It hurts when you swallow?" "Yes, it hurts when I swallow." "And that's the pain you're feeling?" "Yes, that's the pain I'm feeling." I said, "You have esophagitis. You have an inflammation of your esophagus. What they need to do is either a barium swallow or an endoscopy to go down there and see what's wrong, see why your esophagus is hurting." He said, "This isn't your heart." Well, I'll tell you what. It took 2 more days and 2 teams of 6 doctors each to decide, I think we better do an endoscopy and see what's going on. Maybe it's esophagitis. So 2 days after I made the diagnosis, they went in, stuck a scope down there and said, holy cow, she had swallowed a pill and it had lodged in the esophagus, disintegrated, and had inflamed the esophagus so badly that it looked like raw hamburger. What really kills me is that this poor woman was in so much pain for so many days because nobody listened to her. Nobody had a vested interest. Her doctor, he heard chest pain, said go to the hospital. They heard chest pain at the hospital. They said heart disease because you have known heart disease. Nobody did anything like taking a history or listening. So I will tell you, if you go into a hospital, you make darn sure that they know why you're in the hospital and that maybe somebody cares about why you're in the hospital. I had a patient in my office the other day tell me a little story about his wife. She was also in the hospital recently. Now, like I said, I've heard many stories like this since, but this was an interesting one. This is a very intelligent man. He's accomplished, well-to-do, and his wife was thought to have had a stroke, and they immediately wanted to give her heparin. And he said, well, she just had surgery 3 days ago. You need to check with her surgeon to make sure it's okay to give her heparin because, as an intelligent person knows, heparin can cause bleeding at the surgical site, and then you have an even bigger complication on top of whatever was wrong. The patient had facial numbness on both sides of her face. An intelligent, well-educated physician would not first jump to the conclusion that the patient had a stroke. Again, I'm just an old-fashioned doctor who would have listened to the patient. If a patient has numbness on one side of their face, it's a definite possibility, but strokes rarely affect both sides of the body simultaneously. And what's really interesting is my patient knew that. So he talked to the nurse. He said, no, you cannot give her the heparin. Check with her surgeon. And the nurse said, well, you just don't understand our protocols. And the husband replied, and I'm quoting him again, I understand your protocols just fine, unquote. But he pointed out her recent surgery, which he said is noted right on her chart. And then he said, quote, you need to know your patient first and then institute your protocols, unquote. That is one of the best quotes I've heard from anyone in a long time. I don't care what order you're given as a nurse or a physical therapist or any other staff. I don't care if you are the physician giving the order. You need to know your patient first and then institute appropriate care. Now, there may be protocols that you will want to follow, but sometimes common sense really is more important than your protocols. And I think this is an extremely important concept of protocols or hospital finance policies overriding common sense. Going back to my own hospitalization, when I was in the hospital, luckily I was completely with it. And what they do these days is they have a whiteboard that's on the wall across from the patient. And I was reading the name of the nurse I had and the name of the tech that would be attending me and certain other facts. And it said low NA diet. Now, if you happen to know what NA is, as many people do not, they don't know their chemistry, they may not recall their high school chemistry, but lucky me, I happen to be a physician, and I know that NA stands for sodium. So here I am, unable to keep my blood pressure up, and they put me on a low sodium diet. Sodium, salt, is what is necessary for the body to keep your blood pressure up. I called the nurse in, and I said, "Can you take a look at that? It says low sodium diet. You know that I'm here for hypotension. I can't keep my blood pressure up, right? If you keep me on a low sodium diet, I will never walk out of this hospital alive. Can you see that that gets changed?" And her answer was, "Oh, that must have been written by the physician's assistant who admitted you from the emergency room." I don't care who wrote the order. I don't care that it was a physician's assistant who had no part in my care, who some other physician had designated to write the order. She said, "We thought you were here for a cardiovascular problem, so they automatically put you on a low-sodium diet." I said, "I am not here for a cardiovascular problem." I said, "I'm here for a vascular problem, low blood pressure." Common sense would say you don't put me on a low-sodium diet. 3 hours later, the order was changed, which is really good because hospital food pretty much sucks without salt. But be that as it may, at least I was able to get some salt in my diet. So sometimes using your intellect, your common sense, is overridden by the idea of protocols or financial consideration. That's probably true in many, many situations and not just in medicine. But you know what? In medicine, not thinking things through is dangerous. But what's really scary is it's also very, very commonplace. In fact, I would like to ask that people write to me or call me with your own stories. I'd like to hear about what happened to you in your health care, in your hospital stays, in your emergency room care, and see if we can't shed some light on what's going on in medicine. Not what the hospitals are telling us, not what the government and the pharmacies and the medical device companies are telling us. I want to hear from you, the people who have experienced medical care firsthand, and find out what's going on. Next, we'll talk about what you can do to protect yourself and make sure you get the care you should be getting right after this break. One of the things that you can do to protect yourself, if you are not a doctor yourself, thank goodness I was, at least have someone with you who cares about you when you go into the hospital. And if you can, have someone who is knowledgeable. I don't care if they're a nurse or someone else involved in the medical field, but have someone who knows something about what's being done to you and supposedly for you. Because honestly, even though I was a doctor, I was out of it half the time because I couldn't think. My blood pressure was so low. You want someone present to watch out for your well-being. It's really helpful if that person also happens to have a somewhat forceful enough personality that they're willing to speak up on your behalf. I'd love to know if there are services available, if you know of any advocacy services that will go with a patient or examine their chart once they're in the hospital. Please contact me. Let me know. I'd love to talk with these people and maybe get them on the show and let our listeners know what else is available. For the time being, all I can do is say, I hope you have somebody with you. We're going to institute a feature here today called the OMM Moment. I'll have OMM moments throughout the podcasts of the future. They're stories of osteopathic medicine in action. The details will always be changed to protect privacy only, but the basis of each story will be quite accurate. Today, we're going to talk about a woman who had a severe but benign tremor of the head and neck. It means she'd walk around with her head and neck shaking, but she had nothing else wrong with her. It was probably a product of a central nervous system problem, something deep in her brain, but it didn't affect her life or her quality of life. She was quite functional. She was intelligent, very nice. And she'd had that, probably, this tremor, for most of her adult life. But what was interesting is that she also had severe neck pain for about 15 years. She'd been to a number of doctors. Now, the pain interfered with her daily life. All anyone ever focused on was the tremor. And they said, nope, your pain is the result of the tremor. Nothing can be done about it. Neurologist would say, nothing could be done about it. Her regular doctors, nothing could be done about it. She came to our clinic, and I was called in by one of my colleagues, a physician's assistant, and she said, would you mind taking a quick peek at this patient and see is there anything you might be able to do with osteopathic manipulation? So I took a moment out of my schedule. I went in, introduced myself, and I asked the patient questions because that's what a good doctor does. They get a good history. And then I said, do you mind if I do a little physical exam? Oh, that's right. That's another thing that doctors are supposed to do that generally they don't do much of. I'm sorry, I do not consider sticking a stethoscope on someone's chest or a blood pressure cuff on their arm a real physical examination. I put my hands on this person. I checked her neck. I checked for tight muscles. I checked to see if ligaments were injured. And lo and behold, I could reproduce her pain by pushing on parts of her neck. Now, that had no effect on the tremor, but that's not what we were aiming at. I said, you know what? I think I might be able to help you. Why don't you come on back into me? So we set up an appointment. She came back in, and with osteopathic manipulation, I was able to cure, not alleviate, not make a little better, but cure her pain the first time that she was treated. Now, I told her the pain is going to come back because it was actually the result of some injured ligaments she had in her neck. We could repair those with something called prolotherapy, which is an injection therapy. And at some point in the future, we will discuss exactly what prolotherapy is, why I would want to use it, and why someone would be willing to let me stick needles in their neck. But suffice it to say, prolotherapy causes the body to go to an old injury, think it's a new injury, and go through the process of healing it. So we did the manipulation. We did 3 sessions of prolotherapy, and this patient was totally cured of her pain. Her pain had absolutely nothing whatsoever to do with her tremor. It had to do with something entirely unrelated, but everyone saw the tremor and ignored everything else. Not exactly what I consider good medicine. I hope you've enjoyed today's show. As always, before we sign off, I want you to know your feedback, comments, concerns, and even personal stories are welcome. You can either write to me, Dr. Mitchell Cohn, at Medical Radicast at medicalradical.com. That's Medical Radicast, Radicast, at medicalradical.com. Or you can call and leave your feedback, comment, or story as a voice message on our Skype line at 734-931-MRAD. That's 734-931-6723. Your voice may even make it onto a future podcast. Thanks for listening to Medical Radicast. I hope you've learned something you didn't know before, been entertained along the way, and will now maybe even take action to improve your health or healthcare, whether doing a little research, looking for a new doctor, or even just being willing to ask more questions to the people you've trusted with your healthcare for so long. Your health is in your hands, and that, my friends, is a radical idea. It's been my pleasure to be your host on the Medical Radicast. I look forward to speaking with you next time. This is Mitchell Cohn, D.O., the Medical Radical.
I got everything you need.